So for those if this is your first time, my name's Dr. LeMoine. I'm a physical therapist and I'm kind of co-founder of PhysioU. And this is probably I think it's our 8th student webinar now for every Friday. And I have 2 students, Cameron and Chris, who kind of help man the chat as I'm kind of lecturing, talking. So if you guys have any questions or comments or anything at all, don't feel like you have to wait till a good time. Just throw it in there. And then when there is a time, Cameron and Chris kind of will read them out loud. But also if you want to verbally talk at all, feel free to unmute yourself and ask a question. I mean, the more interactive this is, the more everybody else kind of seems to gain and benefit from it versus just hearing me talk the whole time. Right. So with that being said, right, today we're going to do a low back pain with mobility deficits, right? So the CPG for low back pain is a very thick, long one because it covers pretty much all the low back conditions versus some of the other joints. Each CPG has its own little thing. Like I think the last 3 weeks we did ankle and we had ankle pain, and just heel pain had its own. Ankle sprain coordination had its own. For low back, it's all of them: mobility, coordination, radiating related. And so we decided to tackle the easiest one first, and that will be mobility. All right, so if you go to PhysioU.com and you sign in, right, and we will click on clinical pattern. Let me share. Can you guys see that? Yep.
Yes.
Okay. All right. So we are under low back pain, right? What do you expect the pain pattern to look like for someone that has a mobility deficit? And so with mobility deficit, we're thinking like mostly it's a facet problem. Maybe it's that facet is due to just a stiffness, or it's maybe arthritic. So DJD, stuff like that, spondylosis. What do you expect that pain pattern to look like? You can either verbally answer it or throw it in the chat. Expect to be unilateral, bilateral, only in the low back, into the glute, into the hamstring. Like what do you think? If we look at these pain patterns here, right, which one of these looks like it could possibly be a facet problem? Right? This bilateral one, unilateral, more of a central, pain shooting down the leg. That's very dermatomal versus more of a vagueness in the leg, or even here, low back pain with a little bit of radiating, right? If you think about a couple of these, actually. Go ahead.
We have unilateral.
Yeah, unilateral. And it doesn't necessarily have to be this very specific to here, right? It could be unilateral with some referral down into the glute or even the upper thigh area. All right, so if we click on that, unilateral pain, right, you have your low back instabilities, you have your SI, but yeah, the most common one, if someone's kind of pointing to their lower back pretty pinpoint, we start to think of a facet problem, especially if it's that low. Okay, so prevalence, right? We know that facet, so again, the terminology is a little different, right? ICF-wise, they call it, hey, low back pain with mobility deficit. The patho-anatomically world, we're going to say, hey, this is a facet syndrome. Based on their age, if there's some degeneration on imaging, they might call it spondylosis or degenerative joint disease. So you have all these names, but really they mean the same thing, right? So if we click on prevalence, pretty common, right? There's lots of different studies out there that talk about the percentage of this being the source of their pain, or their pain generator, they call it, in studies of low back pain. So they inject your joint and you feel better, then they can say, hey, your pain was coming from the joint. Obviously, there's a little bit of placebo effect involved, but that's how they try to determine the prevalence, right? Most of the time, it's going to be in the older population, right? So age greater than 50, especially if we're thinking along the terms of spondylosis, right? However, there's plenty of people that have facet syndromes that are young, that's not degeneration related, right? It's related to posture positioning. It's related to maybe a quick movement, a quick shift, and like their facet just gets irritated and gets stuck, right? They kind of pinch the capsule within it. Right? So don't think has to be over 50. Right? So that would be our prevalence, right? Clinical findings, right? What do you think if you guys had to describe this person, right? So someone comes in and you're thinking low back pain with mobility. What do you think they would describe their pain, or how would they describe their pain? What would be some of their ags or eases? mechanism of injury, how would they present to you guys?
Hyperextension injury, adds extension rotation.
Yep. I agree with both of those, right? So if there's something where they went into extension too much or too soon or too fast, that could irritate the facet because it closes down, right? And then upon having them move, or they may be telling you it hurts when I bend backwards for extension, it hurts when I have to turn to that side. So whether I rotate to that side or side bend to that side. If we think about it in terms of patients, though, they don't really use the words hurts when I extend or hurts when I side bend. They really think of it as words as like functional activities, right? They don't know what necessarily extension means, but they'll say it hurts when I'm reaching above my head to wash my hair, when I'm leaning into the back seat of my car to get something, right? When I'm having to lean sideways to turn the light off, right? So they have certain ags that require them to extend or side bend, right? Exactly. What's a big one? If someone has a facet syndrome, they might have more pain when they're what? What's another big ag for that? Think functional.
Trying to get in and out of bed.
Okay. Yeah, trying to get in and out of bed. So that that transitional zone from, hey, I'm in flex position to now I got to be weight bearing and extension, right? And not even just getting out of bed, but also getting out of a car or getting into standing. Any transition out of a chair, off the toilet, any transition, we're going pretty much from a little bit of flexion into now weight bearing extension, right? You're going to load your facets. We know in sitting, most of our weight's on our discs. And then when we stand up, it transitions to most of our weight on our facet joints, right? So if you have an irritated facet, you're just loading this joint all of a sudden. So yeah, so any of those transitions. So good job. You guys got all pretty much the active range of motion limitations. You got maybe the mechanisms, as well as a big ag that's very common is transitions, right? The interesting thing is, right, people can have acute, subacute, chronic, and those are all going to present very differently, right? So if someone has chronic, if it's a chronic condition, they've had it for a while, maybe it's already 60% better, they're probably going to be able to move through quite a bit of range before they start to get their pain. So it may be end range extension or end range side bend versus your acute person who probably has pain at rest and the littlest amount of extension or transition is painful. So it's same condition, just realize there's stages to this, right? And the evidence is pretty clear on what percentage of range in order to diagnose that level, meaning acute, subacute, chronic. Kind of like last week we did ankle sprains. We talked about how many millimeters of movement is how you differentiate grade 1, grade 2, grade 3, how much range of motion loss. So evidence has tried to give it these objective numbers. Same thing with this condition. All right, good. All right, so if we go to physical exam, right? Right. So what you don't see in there is tons of movement faults, right? If we're thinking a mobility deficit, right, we're thinking, hey, this person has some type of motion limitation. So what do you think our key findings are going to be? What are the tests you would want to do on this person? Again, feel free to throw it in the chat, or you guys can verbally talk it out. It's up to you.
Lumbar range of motion from Sarah.
Good. Lumbar range of motion. Yep. So, and that can be cleaned up a little bit by saying we have active range of motion where they're doing it, but then there's also passive range or overpressures where we're doing it.
Okay. We also have PAs.
Yep. Good. Good. And that's pretty much it. If you guys that's the key finding that you have to do. There's obviously all these tests, right? There's over 80 tests that we teach in our orthopedic program for low back, right? And that's all those 80 tests are not needed for this condition, right? Hopefully they're needed at some point in your low back pain diagnostic categories for other people. But the idea is key findings, really, it's just a mobility assessment, right? I'm going to look at physiologic mobility, which is their active range, their passive range. Most of the time in the clinic, we're not using inclinometers, right? A lot of time, but however, with all of the guidelines, because it gives you a much cleaner number, right? The standard level of error is much less. So that's what the guidelines recommend to use, even though we understand in the clinic, most of the time, it's just us probably using the tape measure or bony landmarks, right? And so remember, besides just active,
And
we're also
standing
doing
with the patient's feet
passive
shoulder width
overpressure,
apart,
right?
have her bend forward
So you're
as far as you can and apply overpressure with your hands and forearms to all lumbar
so
segments.
we're overpressing
The three
lumbar
different levels
spine,
of resistance,
help them
and
back
help
up
the
into
patient back
flexion.
up to standing.
Do you guys expect that to hurt or not hurt in a patient with a mobility deficit?
Mitty James said hurt.
Yeah. So we think of one of the common thoughts is, hey, it only hurts with extension when the facet closes down, right? That's what we think of. Oh, it hurts with extension, side bend. But often, if you have a facet, a joint irritation to mobility, active flexion may be okay because most of that's controlled by your muscles, right? Your muscles are controlling you down. Your muscles stop you from going all the way. Your hamstring pull. You don't really get to end range lumbar flexion of your joints with just normal active range. However, with overpressure, you have them take their knees out, they bend their knees a tad, slack the hamstrings, and you really crank on their joint in the flexion, right? I'd expect that to hurt. It's a mobility deficit. We're stretching this facet joint that doesn't want to move fully.
Have the patient cross their arms across their chest, lean their head against your head. Use one hand to stabilize the lumbar spine, and then backwards. Again, 3 different levels of resistance, coming back up.
What's the consensus on that? You guys expect that to hurt? Yeah. Someone that moved that far back, how would you categorize them? Acute, subacute, or chronic?
Chronic.
Yeah. Chronic, and that doesn't necessarily mean chronic, meaning like persistent pain, like psychosocial stuff. Just chronic means they've probably had it for a while. Their tissues adapted a little bit. It's not super sensitive. It's not inflamed. It's not irritated. It's just a limitation in motion. Yeah, but they moved pretty darn far, right? And it's important to do that because now what we're trying to differentiate between is contractile versus non-contractile. So even though, hey, they've been back, ouch, it hurts, sometimes we're taught, oh, they already had pain with active. Do we really have to overpress it? And the answer is not necessarily, but if you're trying to differentiate, I'd expect if I do it passively, it should still hurt the same because it's a mobility problem. Versus if it's like a muscle contraction problem, it should feel better, right? So we have flexion extension. I'll kind of fast forward a little bit, right? We have side bend, right? We expect it to hurt towards the unilateral side. But also, if I go far enough
down to 3 different
to
levels.
where you're pulling that joint open, it may hurt as well with opening end range.
Place one hand on the lateral posterior part of the patient's lumbar spine, armpit on shoulder, take into side bend, rotation, and extension.
And then here we have
Again,
quadrant.
3 different levels of resistance, looking for reproduction.
And so quadrant is actually one of those tests that is considered a key finding in your diagnosis of a facet syndrome or a mobility deficit. So when they talk about these clinical prediction rules, right? Or is there certain tests that have good sensitivity, specificity for this diagnosis? Quadrant is one of them, right? So passively, you just take them through flexion, side bend. I'm sorry, not flexion, side bend, rotation, extension, and it should reproduce their symptoms. All right, okay. So we kind of went through all of our active range, passive range, right? The other one you guys mentioned was your accessory mobility, right? So we can do centrals and we can do unilaterals, right? So those are, again, those are a good way to differentiate between maybe some soft tissue and maybe a joint, knowing that some of the soft tissue and joints lay right over each other. So what you're looking for is, well, let me ask you guys that. How do you know if I'm doing a PA and it hurts, how do I know if this is, maybe I'm pushing on a muscle that hurts, or this is, oh yeah, this is the joint. And I think this is a mobility problem. Like maybe both would hurt. How do you differentiate one versus the other?
Compare one side to the other.
Okay. Okay, what are you comparing for? One side hurts, the other side doesn't hurt.
Also have moved different amounts.
Good, nice. All right, so you're looking for amount of mobilities. So sometimes we palpate and we're looking for pain because it helps with the diagnosis. Sometimes it can make it messy, right? Just because it hurts doesn't mean it has to be stiff, doesn't mean it has to be the joint, right? So a lot of times we're looking for how much does this move compared to the other side, not even if it hurts or not. right? And there's these scales, right? Those 0 to 6 scales, or there's another one that's like 0 to 50, amount of how much motion. And you're just looking to see how much does it move compared to the other side.
We
Someone
also
with
have, you can reposition them into flexion and extension and reassess.
yeah, change positions. And if the joint opens more, closes more, I'd expect if it's a joint issue to change. Versus if it's soft tissue, it may be the opposite, right? I put them in a little bit of flexion. IPA, it should be a little less painful, but the muscle might be more painful because now it's on stretch, right? Good. What was I saying right before that? I'm not sure. Lost my change of thought. Yeah, something about mobility. We're looking at the amount of mobility. And that's what makes it a mobility deficit, right? We expect it to not move as much. We expect it to be hypomobile at the site of their pain if we're thinking this is a diagnosis, mobility, facet. Good. All right, so that's, what is that? A 5-minute eval, right? We've done active range of motion pressures and PA. So that's not the end of it, right? So what else would be some associated impairments we'd want to look at, right? We're pretty sure, hey, you know what? This is the facet syndrome, right? What else would we want to look at? What's considered some of our associated impairments that the guidelines, the evidence says these are things you should look at and potentially treat if someone has a lumbar degeneration problem or a lumbar spondylosis problem?
Rule out hip and SIJ.
Okay. Rule out hip in terms of source of pain, like as a differential, or rule out some type of impairment relation?
Differential.
Okay, so differential, yeah. So we can definitely, we can strengthen our hypothesis of it being a lumbar problem, lumbar facet, if we can rule out competing ones, right? So why don't we skip associated impairments and go to differential, since that's where we went, right? So how would you rule out SI? If you're thinking this is a SI problem, right? We want to do a quick screen, so we're under differential, quick screen. How do we rule that out?
P4 test.
Nice, that's one. What else?
We have palpation, SIJ distraction.
Okay, good. There's a cluster that Laslett has researched multiple times that says each test by itself really isn't that great. If we do one of these sacroiliac provocative tests, the evidence is not good. But if we combine them and we can get 3 or 4 of them to be positive, then it really strengthens the case. But if 3 or 4 are negative, then it really tells us it's probably not an SIJ problem. Do you guys know what some of the other, in that same cluster, somebody threw out one of them with that P4.
We have SIJ distraction and a stork test.
Okay. So the distraction one is part of the cluster. The stork test is more of a mobility deficit looking at motion, not necessarily part of the pain provocation test. Think of...
We have compression, and then we also have another thigh thrust.
Yeah, good. Okay, yeah. So the initial 5, right, were the posterior pelvic thigh thrust, compression, distractions, sacral spring, which is a prone, and then Geinsland's. Like those are the original 5. But really what he's narrowed it down to is these 3 important ones: posterior pelvic provocation test, sacroiliac distraction, and compression. And so if those 3 are negative, then chances of them having an SIJ related pain is very, very low. If those 3 are positive, chances are of them having an SIJ related pain are very high, right? So with the posterior pelvic thigh thrust, right, you're just creating a gap underneath the pelvis, and then you're creating, you're pushing posterior into the table through their femur, creating a shear on the SI, right? Do you guys see any issues with, if someone has an acute facet problem, someone has an acute facet problem in their back, and you're doing this test to rule out SIJ, do you see any issues with it?
With the patient supine, take their hip and knee into flexion and roll over into adduction to allow you to place your hand under the sacrum. This creates a spacer or a wedge. Roll the patient's body weight back over and apply a posterior directed force through the femur down to the sacrum.
What do you guys think?
Lumbar flexions occurring.
Okay, so if you flex the hip, you put them into a flexion, so that could pull on it. How about if you're pushing? So I did like 3 or 4 pretty hard pushes through her femur into a posterior glide, trying to move her pelvis. How much is the pelvis supposed to move? Not tons, right? So do you think that low back is going to move? You think L5 might move and L4 might move, and that joint between L5 and S1? So the hard thing is you're going to get a lot of motion at a couple of the joints above and low back. So the hard thing is this may be painful, right? It may be painful, and you're going to think, hey, this is an SI problem. But really what you've done is you've pushed on all the lower lumbar. You've kind of sheared a lot of stuff, which is why some of these numbers aren't the greatest, right? These positive likelihood of a 2, really you want these to be close to a 10. So that's why they've decided to pair them up with now your distraction, right? Where you're pushing the anterior pelvis apart, right? Compression, where you're pushing down, and this can be done supine or it can be done sideline. Yeah. But again, now you're trying to compress the SI joint. So again, we have these tests to help us rule out sacroiliac as a pain generator, right? The nice thing is if they are positive, we can go down and treat that, and that becomes a very narrow. If they're negative, right, tells us we're not treating that. But it doesn't really tell us what we should be treating. We still have to do more lumbar stuff. If they're all positive, you still have to do more SI stuff to decide, is there a directional torsion, or is there some type of slip, or is there some type of muscle that's stiff and holding it in place? So really it's just helping you early on say, is this a SI problem or a lumbar problem? Good. All right, so if we go, so that would be our primary differential, right? Is there any other differentials if someone's coming in with low back pain that's unilateral on one side? What would be another differential? We already talked about ruling out the SI. Someone talked about ruling out hip and thoracic. So above and below, right? How about directly in the lumbar? What else would be competing with maybe a facet?
Disc, neuro.
Okay. So potentially, if it was a disc or neuro stuff, we'd expect maybe the pain pattern to be a little bit different. Maybe we'd expect to be going a little bit further down the leg. There'd be some referred pain, but not always. Majority of the time, yes, but not always. There are times where people have disc irritation without referred pain. So we'd hopefully differentiate that with, it hurts more with flexion stuff, and the more repeated movements you do, it gets worse. What would be literally localized? Like localized
Muscle strain.
Yeah, muscle strain, right? So how would be, does anybody have any good ideas on how you would differentiate maybe a muscle strain from a facet besides what we already talked about, which was palpation, right? We can palpate one versus the other. How else would be a good way to differentiate if their pain was coming from muscle versus facet?
A height hip.
Say that one more time.
The hip is hiked up.
Okay. So if it's on that same side, potentially there's a contraction of the quadratus lumborum. Potentially there's some paraspinal hypercontraction that may be guarding it. So that may be like observation in like their posture or gait. You may see some of these things. Wouldn't necessarily help us diagnose that person, but it may tell us, hey, that's definitely an issue we want to look at.
We also have MMT and palpation. You can feel for muscle activity or a quadrant.
Perfect. Awesome. Yeah. So we know that some of our active range, it's going to hurt whether it's a facet or a muscle because they kind of move together, right? If someone's going into side bend right, muscles are being contracted on the left side, the facet's being opened on one side, closed. So sometimes it can be a little messy. So if you have this thought of like, I'm not quite sure, right, we can always do an isometric MMT, right? Keep them in neutral. Don't let me move you and have them push to the right or push to the left or push into extension. If they're not moving and the facet's not moving, the joint's not moving, should be pain-free. If it's the muscle, we expect it maybe to bother them, right? Or a lot of times what they'll do is you move into these directions, like let's say we go into side bend, it hurts, and then you resist them on the way back up, right? You make them work harder. If it's a facet, it shouldn't bother them because if anything, it's getting less painful. If it gets worse, you think, oh, maybe this is a contractile component, right? But I say, yeah, that would be the primary differential is like, hey, this localized tissue in the low back, is that a facet or is that a muscle, right? Now, if the pain's a little bit lower into the glute, right, then you start thinking, well, maybe this is an SIJ problem because that would be maybe Fortin's point, right? Fortin's point's that very specific point that's an inch below the PSIS that people will point to if they have an irritated sacroiliac joint. Good job, guys. Okay, so that would be our differential. Associated impairments, not very many because we'll probably be treating the lumbar. But the research suggests that if someone has a stiff lumbar and they have a mobility deficit at the lumbar, they probably have a mobility deficit above and below that might need addressing to take stress off of that painful structure. So, and if you think about it, if I have a stiff 60-year-old guy that has spondylosis of the lumbar, he probably has a little bit of degeneration in his hip and probably has a stiff T-spine and kind of comes with the territory of being 60 sometimes. So you're looking for impairments to treat, right? This becomes very useful if they're acute, right? If you can't address the low back directly because everything hurts so much, maybe you need to address a little bit of mobility deficits a little bit further away to start with. All right, nice work. Okay, so that would be our physical exam. All right, if we go to interventions, all right, so we have manual therapy, TheraX, patient education, manual therapy, all right, what do you think are some of the treatments we want to be working on, right? What would be, I'm going to go back a page. You guys don't see that. All right, what do you guys think? What are some common interventions for low back pain with mobility deficits? Start manual therapy first.
We got joint mobs, manipulation.
Okay, so joint mobs. For the person that wrote joint mobs, is there a specific joint mob you would do? It doesn't have to be just that person that answers it. It can be anybody.
For rotation to increase gapping.
Okay. So that sounds like that'd be more of like a physiologic mob, right? They're on their side, right? Any other joint mobs?
Unilateral PAs.
Yep. So yeah, posterior to anterior accessory mobilizations.
Someone also said QL muscle lengthening.
Okay. Yeah, so that is the interesting thing, right? Is that you can technically treat this a lot of different ways, right? So the same person may go and see 5 different therapists and get 5 different treatments, right? It's not like going to Starbucks where a Pike's medium roast is a Pike's medium roast, right? They're all a little different. But the nice thing is, as long as you're in this category of mobility and you're stretching things and you're moving things, then right, this person should get better, right? So if we go down manual therapy, right, you'll see the same thing. There's a couple different options. Now, let's say they're very pain limited, right? You can't do much, right? We may only need to do these gentle grade 1s and 2s. Maybe we do some general traction, right? But also our grade 5, right, our high velocity, our manipulation actually fits appropriately here. All the research shows that these grade 5s, they're not as beneficial for mobility as we used to once think. It's more you're just gating out pain, which allows them to then move more, right? Studies show that on MRIs, the amount of motion that occurs at the joint really didn't change much, but obviously something's going on neurophysiologically that's allowing them to feel more confident, move better, feel like they've been treated. Maybe all of the hypersensitivity of your nervous system is calmed down because of the flood of chemicals from your brain that allows us to move better. So it's fantastic. And these things last up to 10 minutes is what the research shows, whether your blood pressure changes, heart rate changes, there's all these anatomical stuff that change, anatomical nervous system. So your ANS change for up to 10 minutes. So if someone's really, really painful and you really want to get in there and PA them, but you're barely touching them and it hurts, maybe we actually choose to do a quick technique that only lasts for, only takes 30 seconds to do. And then now you've bought them 10 minutes to get some motion in there and really get some movement in there. So when I went to PT school, these manipulations were kind of saved for the non-acute person, someone who just really didn't move well, but they could handle everything and they were acute, and it was like a ramp up, right? And it really was just thought of as a big mobility deficit. That's it. But now all the research is showing that there's more to these than just getting them to move, and that they actually have really good benefit in the acute people, right? Good. So that would be kind of like for our pain modulation, right? If we're going to choose, let me go back one, right? If we're going to try to improve mobility, so let's say they're no longer in this acute phase, but they're in subacute, chronic, right? And we're trying to improve, we can definitely do those manipulations we talked about, right? Whether it's more focused on the lumbar rotation, or maybe it's the sacro-lumbar. There's a pretty good clinical prediction rule that tells us who's going to benefit from this neutral gap or this sideline rotation. You guys know the prediction rule, anybody? Some of the factors associated with it?
Pain less than 16 days, no pain distal to the knee.
Good, it's 2. Anybody got 3 more?
FABQ less than 19. Greater than 35 internal rotation, at least on one hip.
Mm-hmm. One more.
One more.
It's an objective.
Hypomobility.
Yeah, good. All right. So any students that are getting ready to take their boards anytime soon, memorize that. That will probably show up 3 times on your test. That or your OCS and that. Yeah. And the nice thing to remember that is the numbers. Sometimes you can't remember the numbers, right? 19 is the FABQ. 16, right, is the days. If you add that together, that's 35, and that's your hip internal rotation, right? So as long as you can remember the math, I guess you still got to remember 2 out of 3, right? So yeah, and out of those, the studies show that out of those 5, there's one that had the biggest influence on the outcome. What do you think, which one had the biggest influence on the outcome?
Hip internal rotation.
Nope.
Acute.
Yeah. So the day-wise, if you're thinking days, yes. So out of the 5, right, the people that had this, that fit the less than 16 days had the most positive outcome following the manipulation, this type of manipulation, right? And the nice thing is this study has been done multiple times by different people to validate it and revalidate it. And it seems to always come out on top. Meaning if someone is not super chronic, where they have persistent pain and they have all these thought viruses and psychosocial issues, it's just an acute low back pain for 2 weeks. You know what? If you manipulate them, get their spine moving, right, they should do pretty good. The nothing radiating past the knee, right? The whole idea of that is you're trying to rule out any type of neuro problem, right? Because studies show that a facet can still cause pain into the buttock, into the posterior thigh. It can be referred down that way and still be coming from a facet, right? But if it's going past the knee, right, there's no studies that show the facet can refer past the knee, right? So that's a good thing. We can say, hey, this is not a nerve issue, right? The hip internal rotation, the whole idea about that is, hey, if they have 35 degrees of hip internal rotation, it's probably not a hip issue, right? Think of all the hip issues out there. Most of them have some type of pain with internal rotation, right? Whether it's an FAI or a labral or hip OA. But the idea is they're saying, the hip is pretty clean, meaning this is probably just a localized back issue. So they're more likely to get benefit from it, right? Obviously the hypomobility, so doing your PA and getting the hypomobility, that makes sense, right? Something stiff, you're going to try to manipulate it, make it move better. And then the FABQ one is just saying that these people aren't anxious or not scared. Again, there's less of this idea of persistent pain, thought viruses stuff. So it's really just describing somebody with a localized, acute, low back pain without all the other stuff that sometimes comes along with low back pain. And those people get better quicker or have the best outcome. So it kind of makes sense if you think about it, right?
Dr. LeMoine, do you mind quickly just touching on the FAAOMPT and what exactly it's used for and what it is?
Yeah. So the FABQ is a fear avoidance questionnaire. And there's two parts. There's one that's like a work part and one like an ADLs. And it's just a questionnaire asking them how ready they are, how safe they are, how fearful they are about doing certain activities, right? And I'd say there's one big question on there. This is a part of this, but when we get to persistent pain, the idea of, are you fearful that physical activity will make, or do you think that physical activity will make your pain worse, right? And that's a big one where they're like, I think that physical activity will make it worse. We have our jobs cut out for us, because what are we probably going to send this person home with, right? What does the research say this person probably needs to do, right? Low back pain. It is no rest. It's not resting, right? It is be active, be moving, do physical activity, do exercise. So if they're fearful that when they move and they act, they're going to make their symptoms worse, right? Or their condition worse, then we have to make sure they understand that, hey, every time you hurt doesn't mean you're making your condition worse. It's part of the rehab. Yeah, it's just a way to get inside their brain a little bit and see how fearful they are about doing regular life stuff. And then there's another part. It's about the work part. It's a questionnaire. I think maybe we have, I know we have the catastrophizing and oswestry and stuff like that. I'm not sure if we have the FABQ in there. I'll check when we get there. Good question. Okay. So manipulation, right? Not all manipulation is taught in schools. Not everybody's comfortable with it. There's some people that aren't as tall, and there's patients that are very big that make it hard to do that. So realize we have other options, right? We can always do PAs, whether it's central, unilateral, but we can also do, there's tons of physiological techniques, right? So you think about, there's manual traction, there's snags, whether you do snags for extension, snags for flexion. I would say I do this often, right? If it's someone who on the table, they actually feel pretty good on the table, I can PA them and it doesn't really hurt them on the table very much. But really in standing and weight bearing, it hurts mostly in weight bearing, right? Because gravity is compressing their joints are closer together. And that's really the only time I could reproduce it. So this is the very non-acute person. A lot of times if I just have them do that ag and I just give them a little bit of traction at that joint every time, we do that 20, 30 times. A lot of times for some reason, their muscles start to activate better. They learn to motion, they get less fearful, and it seems to work well for those people. Yeah. So just kind of doing these sustained gaps. So you add a glide, they move, come back, take the glide off, right? So these are kind of like considered the MWMs of the spine. Right. Good. Okay. So that would be our hands-on component. Oops, where do we go? Right. So we can do accessory mobilizations. We can do physiologic mobilizations. We can do high velocity thrusts. I think somebody had mentioned, oops, what's going on here? I think somebody had mentioned some type of muscle work. So soft tissue, right? We can definitely do soft tissue if you think that the joint's being restricted by the muscle on top of it. Sometimes you need to loosen up the muscle and then you can actually get to the joint, right? Because what does a muscle do? What does a muscle do when you have pain? Right. If someone's in pain and it's from their joint, what do you think the muscle does?
It guards, tightens up, spasms.
Yeah. So do you think that the less amount of time that muscle's been able to guard and protect, the better outcome you have with your joint stretching? Yeah, maybe that's another reason why this whole 16 days is the most beneficial. If you've had someone who's been kind of guarding and protecting for 3 months, now you have this soft tissue that's probably pretty darn stiff and short, maybe. Good. Okay. So Therex. If we move away from manual therapy, Therex, most of our Therex should be in this mobility category, right? We want to match whatever we did in the clinic, our manual therapy work, and we want to match it to whatever's happening at home, especially if we reassess and they felt better. So our Therex component, right, not sure what's going on with my internet today. So our Therex component should match. So all of our mobility should be stretches for the lumbar spine, self-gapping for the lumbar spine. that. Yeah. And then the other thing is, yeah, here we go. So extension work, flexion work, rotation work, and then maybe even the thoracic spine, right? So the section. So you have all these different options to improve lumbar extension, lumbar flexion, lumbar rotation, right? So I would say, where would you guys, someone has a facet problem, right? Where would you guys start, right? You just worked on PAs and maybe you did some rotational stretching, right? What are you gonna do for HEP? Would you work on extension, flexion, right? It's a tough question. What do you guys think?
Flexion. We'll work on flexion. We can do prone press-ups on elbows if I treated with the PA, and we'll work on flexion to open it up. We can also do hand heel rocking or anti-rotation.
Okay. Good. So I heard prone press-ups, which is more of extension, quad rocking, which is more flexion, right? How do you know which way to go into? How do you know if I'm going to treat, do I want to treat extension? I'm going to send them home with prone press-ups and back bends, or do I want flexion where I'm going to treat them with double knees to chest and quad rock backs?
Sarah says it depends on the centralization direction.
Okay. Okay. Would you go after the one that, so when we think of centralization, we think of direction of the pain changing location, getting bigger or farther away from the spine. So centralization, if we're talking about just acute low, if we're talking about low back pain that's mobility and it's pretty localized, there may not necessarily be centralization and peripheralization, meaning it travels. Now the pain itself, the intensity may get up and down, right? This hurts more, this hurts less. So I guess, would you do an exercise that makes it hurt more, or do an exercise that makes it hurt less in the moment for this mobility deficit?
Jeho and Jonathan say it depends on symptom irritability.
Okay. That's a good, safe answer.
Sarah, to her centralization, one says exercise that hurts less.
Okay. Okay. So how about if I did this for you? If I had a patient with elbow pain, right? It's a mobility problem. It hurts when they extend and they're limited. So they can't straighten their elbow all the way and it hurts. But flexion doesn't hurt them at all. What do you think you would send them home with? Would you send them home with flexion stretching or extension stretching, even though extension hurts?
Extension.
Exactly. Even though it hurts and flexion doesn't hurt?
Yes, for pain-free range of motion.
Exactly. So sometimes with low back pain or with lumbar pain, we get a little conservative because of how, oh, hang on one sec. Sorry, my youngest kid's in here. Give me 2 minutes, Maddie. We tend to protect it a little bit more and try to stay out of pain. But remember, if it's a mobility deficit, 15 minutes. If it's a mobility deficit, we really want to improve that mobility. And sometimes it may hurt when we do that, just like it may hurt when I stretch the elbow into extension. Just why it may hurt someone's anterior ankle if we're working on dorsiflexion. And we're kind of okay with that. Like, we've made the call that, hey, you know what? This is a restriction in motion. It may hurt when we work on it, but if we give you more motion there, you'll feel better. That theory should fit the same for lumbar, even though people don't think that way. There's a lot of fear, even from practitioners. There's a lot of fear about treating low back pain and causing pain, right? So now if someone has an extension problem and it's a stiff facet and it's not moving well in the extension and it's painful, and I PA them and it hurts while I'm PAing them, but then they get up and they feel better, right? I'm going to push them into extension at home. As long as, I think you guys said, as long as the irritability allows, right? They get up, it hurts while they do it. They get up though, they feel fine. They recheck it, they feel better. I reassessed, fantastic. Now for the acute person, maybe there's a lot of inflammation, there's a lot of guarding. Maybe we go the opposite direction and purely just calm the system down. You know what? You can't even get on your hands and you can't even get on your elbows to work on extension right now. It hurts so much that, you know what, let's just get motion anywhere. I don't care where we get motion at. Let's go into flexion, right? Maybe that's the elbow guy that it hurts so bad in his bicep spasms when he tries to extend. We're not going to just keep cranking on it. Okay, you know what? let's just do some flexion to neutral, flexion to neutral. Let's just work on any motion in that elbow to calm the system down, right? So this is where our acute versus chronic person, or high irritability, low irritability, we may choose. Eventually we want to get them extension because that's the motion that they lost. We just might have to choose flexion first if we have to. But one of the takeaways from this is, don't be scared to have people feel low back pain if it's a mobility deficit, because you would be okay with that with any other joint in the body. Agreed? If irritability allows, like you guys said.
Nancy made a great point and says, teach the patient the difference between pain and discomfort.
Totally, yep. Hurt, not harm, right? That's one of Lorimer Moseley's big pain scientists in Australia. This thing's, hey, it's hurting. I get it. It hurts. You're not harming yourself. If anything, you're helping yourself, right? All these H's, hurt, not harm, but help, right? Yes, it hurts, but no, you're not damaging anything, right? But again, that's you being confident in your objective assessment that says, hey, this is a mobility deficit. I think this will make you better. I'm pretty confident in that. Good. Okay. And so again, the idea is you have lots of options. So whether it's extension, you have a couple options, whether it's flexion, you have options. And this is where you can be super creative. I mean, we chose a couple of the common ones to film, but we could have filmed 20 exercises for each category for low back pain. Right? If you guys go to social media, there is an exercise, tons of exercises. So just have a couple. Good. All right. So if we go back from mobility and we say, you know what about motor coordination? Right? Again, there's not much coordination that we're going to treat if it's a mobility problem, because we want to treat the mobility, treat what the problem is. However, someone who has a lot of pain, we can't do too much. Maybe we need to just work on some of the global pain reduction techniques. So such as diaphragmatic breathing, abdominal bracing, quadruped rock back to get some gentle motion, not really going into high flexion, right? So we're not really going to sit on your heels. It's just rocking back with shoulder and hip support, right? So there's a lot of studies that talk about, regardless of what type of back pain, but if they're in a lot of back pain, just diaphragmatic breathing, getting some of your nervous system to calm down, getting your abdominal muscles to turn on, that can help with low back pain, right? Again, we're not treating necessarily mobility here. We're treating more just pain at this point, right? So now the last one would be functional movement, right? So if someone has a mobility deficit, we improve mobility, they feel better, right? That really shouldn't be the end of our treatment, because studies show that up to 80% of people are going to have reoccurrences of low back pain. Once you get it once, you're pretty much going to get it again, right? So the idea is, can we then, in the later stages, say, you know what? Can we work on some motor control to prevent reoccurrences? As well as studies show that just being overall active, doesn't matter what you do, whether it's swimming, biking, walking, any type of cardiovascular program, have a decrease in reoccurrences than those that are sedentary, right? Our spines are meant to move. You just worked on them to get them to move better. So let's make sure that they understand, hey, just being general motion is good for you, right? So just cardiovascular program. The motor control is where you can try to then differentiate it and make it patient specific, right? Not everybody needs the exact same thing. So what are they doing? What are they doing in their spine that maybe makes them a risk for reoccurrence? Do they extend too much? Do they rotate too much? Do they flex too much? Do they have problems when they do squats at the gym? So you have all these different types of things. So people with flexion problems, is it when they're getting dressed? So you just have all these different, think of it as you're training functional movement to prevent reoccurrences. This really shouldn't be our visits 1, 2, and 3, because it should be really focused on mobility, 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 get that motion back. But towards the
So
end,
I have a question in regards to that, Dr. LeMoine.
Yep. Go for it.
So let's say you got mobility back in session 1 or session 2, and they have more range of motion and less pain. Is it all right in that same session if you have time to work on motor control within that new range? Or I was told that.
Cameron? Hey, Cameron?
Yeah.
Hey, sorry, will you say that one more time? Sorry, my daughter came running in the room. Sorry,
No worries. So you get more range of motion by working on mobility.
Yep.
And then I went and decided to do motor control within that new pain-free range of motion. But then I was told, well, you don't want to do that because then you don't know if mobility was the ultimate thing that helped them. What are your thoughts on that?
I think that if you are still working into that new range, so let's say They bend back, and we'll make these numbers up. They bend back and they had 30% lumbar extension compared to normal, right? And then you treated them with whatever stuff you worked on, and now they're up to 75% of their mobility. If you're doing an exercise that's getting them to that 75%, awesome. So whether it's a strengthening exercise to 75%, it's a motor control to 75%, as long as you're moving to that range, you're working on mobility. So if I'm going to do prone press ups and they just hinge at L2-3, and I want them to move at L4-5, I may have them abdominal brace, properly change their legs, and do press ups. So they're still working on extension, but that would be like a motor control extension versus purely straight up, hey, you know what? Just push it up. Don't worry. So I think you're totally okay adding on higher level motor control stuff, but the idea is it should not be this isometric dead bug at 90-90 where their spine's not moving, right? So if they're doing stuff in extension, that new range, and they're controlling that motion, I'm all for it, right? Why would we want it to be sloppy range if we can have it coordinated range? But the goal, I think, at this point, early on, is, hey, make sure they're getting to that new range you just gave them.
Got it. Perfect. Thank you.
Yep. Good question. Okay. Yeah. So then this would be the functional stuff where it's more related to specific things, right? And the nice thing is, if you have, like, so you're showing them these videos, right? Or you're learning, you can just send these. A lot of these functional ones can be emailed. So you click on this little email button here, and they get emailed to your patient, and it shows them the wrong way and the right way to do it, right? So that way they go home and they realize, like, hey, you know what? I don't remember what he talked about squatting. I don't remember he talked about with bending or getting out of the chair. It gives them options, or it gives them something to watch and look at this part. Because again, visual cues is very important for when we are training motor control. Okay, so lastly, if I come out of this, right? We talked about cardiovascular. So let me go out again. Patient education, right? So under patient education, right, it's either built into the interventions component, right, or, right, there's a whole new app that's just kind of patient education, right? And so lumbar mobility. So this would be one we might want to decide to, you know what, I'm going to click here. It's a 3-minute read or a video. Send it to your patient. And it's about lumbar mobility. Nice thing is it talks about kind of what the benefit of spinal manipulations are. Is it safe? What are the benefits of just exercising in general, being active? And it gives a couple of common videos for just motion in the spine, right?
Dr. LeMoine, do you mind showing them exactly how you would send that to a patient?
Yep. So if I'm here, patient education app, lumbar, right? So lumbar mobility. If I click here, I click on it, and then it just populates. Oops. I clicked it twice. There you go. It just pops up in your email, and it sends them the link. So they do not need to have access to PhysioU. They do not need to sign up for anything. There's no cost. There's no anything. They just click on this link, and it's a non-password protected link. So send it to your mom, your dad, your brother, your patient, and you just put their email address in, right? And you can always change where it comes from. So here it's coming from my Yahoo, just because that's my default. But you can change it to like your work email if you don't want people to have your work email. Or if you don't want people to have your personal email, sorry. Okay. So let me go back to that. So that would be under the patient education app, right? Thing. Cool. So I'm going to stop sharing for a second. Let me close this out. Good. Cool. All right. So I have not read any of these chats. So I apologize if anybody wrote things personally or privately to me that Cameron and Chris were unable to read. I will read through it a little later to double check if I did. But at this point, you guys have any questions? All right. Again, lumbar mobility is the easiest of them all when we talk about low back pain, right? The guidelines have really good evidence. They're all grade A's for working on mobility. It's just how do you want to work on it? And that's the nice thing. There's lots of different options to work on it. Let me go up to this real quick. And then I'll share screen one more time. Good.
We had another question. Do you have any more clusters that we should know? I know that a lot of people like the
Clinical prediction rule.
Yeah.
There's a cluster for facet pain, a CPR. Let me get this. Let me find my picture so I know I'm talking. There's a cluster for prediction rule for just diagnosing a facet, with the idea that, and it's all based on like subjective stuff. So it's worse with transitions. It's worse with prolonged standing. Their age is greater than 45 and a painful positive quadrant. So like those four things, and no radiating pain past the knee. So that cluster there makes you confident that you actually are dealing with a facet problem. The big one there being quadrant. And then one of the interesting things was if they feel better with walking than standing in place, better with walking, that actually leads to a higher likelihood of it being a facet. So I know when I was reading that, I was like, oh, it didn't necessarily I would have thought walking would have been painful because of the motion. But like, the idea there is your muscles are activating, your muscles are taking some of the load. First, when you stand, you're really standing on just your facet joints. So that's a prediction rule for diagnosing versus the other prediction rules more for treatment of using a spinal manip, right? And we also remember we have that SIJ prediction rule where if you have 3 out of the 5 positive, right, pain provocation for posterior pelvic thigh thrusts, compression distraction, those are all related to a high likelihood. It has a good specificity of it's an SI problem. Good specificity and sensitivity. So positive, rule it in, negative, rule it out. It's good for both. There's other prediction rules that are for other issues, such as instabilities and radiating pain that we'll talk about in the future when we do those. But as far as mobility, I don't know of any more purely for like a mobility facet. I think those are the big ones. Good question though. Good. All right. So again, the recording, everything got recorded. You'll get an email with the recording, as well as we'll do another one next week. And next week will be more the coordination deficits. So looking a lot into like Stuart McGill, Shirley Sarman's work, and all their research into how we're moving, not necessarily not moving enough like a mobility, but we're moving too much or we're uncoordinated and stuff like that. And that will be, again, same time next week, Friday at 9. And feel free to shoot me an email, guys, if you have any questions. Otherwise, there's nothing else. We can call it.
Awesome. And if you guys want more information, you guys can also go to the PhysioU website under knowledge. There's a couple of different series that we have: mentoring minutes, teaching table. Also, every week we're kind of dropping videos for mentoring minutes and teaching table on our various social media channels. So check those out, and shoot us a comment if there's anything that you would like us to shoot or produce.
So if I go here, if I go to, all right, so PhysioU.com, I don't sign in. You just go to knowledge. This is free for everybody. You don't need to have a password. All right, mentoring minutes. Good. And then we can click on lumbar, because we did today, right? And so we have one on gait with low back pain, 3 key movement tests, low back pain classification. So that would be a good one to watch, a quick video that would help you differentiate the mobility. Stuff on Yanda, lumbar pelvic movement control. So allows a coordination one. So the one I would maybe suggest if you were looking for some would be just watching this low back classification, because it's just a quick one that goes over how to differentiate mobility, coordination, radiating, related, on all that stuff. Cool. I'll stop sharing. Cool. All right, guys. Thank you, everybody, for joining. And I will see you guys next week. Again, if you have any questions, shoot us out, and talk to you guys soon. All right. Take care, guys.